Rheumatic diseases can have serious socioeconomic implications in developing countries like Pakistan with limited resources in the healthcare sector. Decision makers are forced to provide treatment among patients. To further elaborate the topic of socioeconomic burden and treatment strategy for uncontrolled rheumatic diseases in Pakistan, we have Dr. Mohammed Haroon, who is HOD of Rheumatology in Fatima Memorial Hospital, Lahore. He has given his services in the field of rheumatology for decades and has done a splendid work in the field of research and publication. He has come from Ireland to serve his fellow Pakistanis, sacrificing his future over there. Sir, please come on the stage and elaborate this topic.
So thank you very much for being here, and it's an absolute pleasure to welcome you all for this little dry subject, if you like, but I'll be more concerned in having some healthy discussion afterward. Hopefully there will be some healthy questions on all this. So the agenda is, rather than talking about the drugs only, I'm going to talk about the scope of the problem, and of course look at the impact of socioeconomic burden in different rheumatic diseases, and of course whatever available options we have, we're going to talk a little bit about this and what could be the solutions. So just talking about our own diseases, for example, we know the rheumatoid arthritis is of course one of the most common autoimmune inflammatory arthritis that what we deal with, and it's very important to tell our patient as well at the same time that how common it is, because most of the patients ask us like, you know, if you look at the prevalence, like it's up to 1% across the world. And I think in Pakistan, I have seen seropositivity much more than I have seen in European countries, for example. And if you look at the data, the 30% of the patients with the rheumatoid arthritis would having some work-related disabilities within first 10 years. So 30%, I think in our population is definitely much more in 10 years' time. And if you look at the estimated cost of this particular rheumatoid arthritis and to deal with these rheumatic diseases, especially rheumatoid arthritis, I'm not talking about the rheumatic diseases in total. If you look at the rheumatoid arthritis only, it's 45 billion euros per year in Europe, and it's $41 billion if you talk about in United States. So definitely the impact of that particular disease is way too much. We know about psoriatic arthritis. We know that it's a very aggressive disease. It's not as mild as we used to think. And again, it's very aggressive. And our own center in Dublin has shown that around 50% of the patient would have some disabilities, some erosions within 2 years of disease onset, even though these patients would have been on DMARDs. And we know that up to 30% of the patient with skin psoriasis would eventually develop psoriatic arthritis. So the scope of the problem is huge. And if you look at the AS, for example, we know in AS, for example, there's the longest delay to diagnosis as we talk about. It's still more than 5 years in most of the countries. Even in the developed countries, if you look at the data, hardly there is any study which is talking about less than 5 years or 4 years. And it's very important that this delay to diagnosis, it's not that we are talking about a silent disease. For example, this is our own study. If you look at the two cohorts, so again, I'm just going to highlight, this is not the silent disease which leads to delay to diagnosis. Rather, in two studies, in two cohorts, 60 to 70% of the patient with the back pain who eventually would have been diagnosed with ankylosing spondylitis have been knocking around the door of different disciplines. They have been to physiotherapists and so on, to the GPs. So it means, unfortunately, there is a delay because of the proper pathways, the proper recognition of our rheumatic diseases is not there. Even today I just put in these two slides. It just, the patient that we saw, I think it was Monday that this young boy was discharged. So I think he came on Wednesday or thereabouts last week. And literally his parents brought him, he was not able to stand up. He was like in his arms, they brought him to our clinic. And again, multiple admissions, all especially the children's hospitals he have been, and the other tertiary care, private, public hospitals he have been, he had already got inflammatory arthritis. And the most sort of devastating and of course the heartbreak story was that this particular patient's case notes, it was written that this is not inflammatory arthritis. So when we told him that this is arthritis, we're going to admit this particular boy, they said like, no, it's not arthritis. So we eventually ended up admitting him. So again, he has a very, very good recovery. Literally within 3 days, 4 days, the patient was able to stand up and weight bear because his knees were injected. We already started him within 3-4 days on infliximab, and again, he was much, much better. And the morning, I think that was this Monday morning or something, when we were going to discharge this particular guy, and the nurse just tells me in my ears, she tells me that इसकी माँ इसको रात को Nalbane का injection देती. So we were all like shocked, like where this Nalbane business came from. So again, what happened was that this particular 12 years old boy who has been suffering from arthritis for last at least good part of 1.5 years to 2 years, he has been on morphine, Nalbanes and all this just because of the pain relief. Naturally, of course, I was very upset. We started, of course, naturally, जो हम करते हैं, we started giving out to the parents. And afterwards, when I left the ward, honest to God, I was just thinking who to blame. This particular mother, oh my, Zaira, his child is suffering, his child is not able to sleep, his child is not able to weight bear, this particular child is not able to sit in the toilet. And of course, he has whatever option this poor mother is going to have, is definitely going to offer to her little son so that at least he can sleep, at least he's able to not at least crying in the middle of the night. So again, I don't know who to blame. So at least I was wrong in giving out, that's what I understood afterwards. Again, I have dozens and dozens of such stories, to be honest. It's a very heartbreaking stories when we talk of these little kids, you know. And this was, again, I'm not going to bore you with all the whole case story, but this particular child, again, was brought about a year ago. He was taken off the school because he was not able to sit down, sit in the chair, sit in somewhere for a longer period of time, was sent to madrasa, कि ये school नहीं जा सकता, चलो मदरसे पा दो. You know the usual story in our villages. So he was sent to some madrasa, but again he was kicked out from the madrasa because he was not able to sit down on the ground and read Quran and so many other things. So he was kicked out of the madrasa as well. And again he was having spondyloarthritis, and alhamdulillah he's absolutely 100% pain-free, able to run around. So with our sort of diseases, there's a lot of socioeconomic burden, and of course the impact is too much. If we look at now the impact, what we know about the socioeconomic burden and the socioeconomic, the class difference in our rheumatic diseases. This is the latest CDC data on socioeconomic burden on these rheumatic diseases from 17 US states. So what they simply looked at was more than 130 respondents. They simply looked at their socioeconomic status and of course the impact on different, for example, the work-related, the physical activities and so on. And very importantly, I want you to look at this particular two slides at least. The social risk factors, what they looked at was the food insecurity, housing insecurity, financial insecurity, unsafe neighborhood, and the fifth one was healthcare access hardship. So 130 people, they simply asked these 5 risk factors to see how many of them have, how many of those risk factors, and looked at their overall quality of life and functional status and so on. And it was very shocking to look at this, the adjusted odds ratio of developing arthritis in these patients. So the odds ratio was 1.92. Means there was a 90% high risk of having inflammatory arthritis in patients who have 4 or more than 4 of those social risk factors. So this is again, you can see very nice linear relationships, means the more risk factors somebody carries, the higher prevalence or the higher existence of arthritis in these patients. So very nice, again, these are another linear relationships. For example, if you look at the limited social activities, limited physical activities, limited work in these patients, and the more arthritis pain in these patients who have 1 or more of those social risk factors. This was another analysis of the same, looking at the same burden, and again what they also looked at was the patient with the low socioeconomic class, and especially people who are living in the rural areas, they have much higher risk of developing arthritis. We know the impact is more, but again we are talking about the new onset or the prevalence or the incidence of arthritis in these rural areas, in these people with the low socioeconomic class is much higher. This is another one, quite a recent one, which also looked at little bit different in terms of the functional status of these patients in people who have rheumatoid arthritis, and what again the worst functional status of the patient who have poor social economic class compared to the people who have a better sort of the healthcare and all this. And the worst of all was that not only they have worse functional status, rather the decline in functioning over time was much higher in the patients who have low socioeconomic class. This is a little older data, but again talking about the same, that the people with the rheumatoid arthritis who have again belonging to the poor background, they unfortunately do worse as regards the higher disease activity, and also having poor functional class, and also having poor quality of life in these patients. And this is the very, very recent one, literature search, systematic literature review, looking at again all these different articles that we can think of, looking at the same things, and again coming up with the same sort of the conclusion that there is a very significant risk and significant association, if you like, between the low socioeconomic class and the worse rheumatoid arthritis related outcomes. This is a scoping review, again looking at the same thing but at a different level, and the medication use, and what again they were talking about, that the medication use were different. There was a massive difference in the people who have low socioeconomic class, again with the people who have better health cares and all this. Again, this is a little older one, but talking about the same, that the patient with the low socioeconomic burden, high socioeconomic burden, the people in the poor or the rural areas would have a longer DMARDS introduction compared to the people who have middle or upper sort of the class. Again, this is a quite interesting one, I thought. So this is a study which looked at, again in states, the same sort of the medical college, the same university hospital. So they were providing rheumatology services to two centers. One was on-site private clinic in their university hospital, and one was off-site sort of the, if you like, the district hospital outreach sort of services. And when they looked at the data, there was a quite sort of disturbing data, if you like, that the same team, same rheumatology, same medical school, same university hospital, but providing to different class of the patients, rheumatoid arthritis patients, they're providing services. And what they found out was that there was a 4.5 years of delay in the introduction of DMARDs, starting the DMARDs in the people who have low socioeconomic class. So it means, looking back, it's not only these patients, unfortunately, with the low socioeconomic class, they have a higher arthritis onset, but unfortunately, for whatever different reasons, they are not getting the proper health care or the DMARDs introduction, if you like. So this brings me a little bit looking at our own data as well, that what, for example, the patients because right now we don't have any long-term longitudinal studies. We do have a lot of cross-sectional assessments made, but longitudinal assessments we don't have. So we have tried to sort of provide a look at our own data as well. So first of all, talking about the registry. So what registry is? Because this is the best way to find the real-world evidence. We know about the randomized controlled trials and all this, but the real-world evidence, the best way to look at is the patient registries. And registries are simply the collection of information about any particular disease, for example, rheumatoid arthritis registry and whatever other disease-related registry. And of course, they record all the information about the healthcare, whatever drugs and so on. So we know, as I said, very little about our own. So we started having this data started in October 2019 from different centers. Again, there's quite a lot of details, so that's why it takes a lot of time. So that's why there is some reluctance as well from other centers, because it takes a little bit of time to complete all those information. So we have more than 2,000 patients already registered of rheumatoid arthritis in this particular registry. And the first 1,001, I just asked my fellow there earlier to just look at whatever have we got regarding this particular the rural and the urban one. So what we found in our patient was 30% of the patients belonged to the rural areas, 38.5% had low education status of less than primary school. So this is another indirect way, which is a validated way to look at the socioeconomic burden, socioeconomic class of that particular patient by looking at their education status. And the patient who have a low, again having less than a primary school, for example, education, they had much higher active disease, high DAS28s, they have a high comorbidities. So in all our patients who are entered in this particular registry, we look at all their comorbidities. So they had a much higher comorbidities and much higher clinical stress. We know in Pakistan, unfortunately, it's not easy to practice. As you can imagine, it's not that easy to just write down a prescription and give it to the patient. You always keep on thinking what this particular patient, where this patient is going to get from. All the stories we hear, that it costs so much to come to for example, us, and then again getting all these medications, cost of the travel, again they're on the daily wages whenever they come. Again, it's sometimes you feel that we need to be a little bit not human when you're practicing in Pakistani settings, to be very honest, because if the moment you start listening to them, I don't know. So cost of medicines, compliance, the beliefs is the worst one. If you ask me, the worst nut to crack in my settings is the beliefs. Everybody comes with the different beliefs. मैंने ये नहीं medicines लेनी, मैंने वो injection नहीं लगवाना, मैंने फला नहीं करना. When they go home, you make them better, but when they come back to your clinic, I don't know, it could be 6 months, although you ask them come back in 6 weeks, and they always come back with the different stories with the worst outcomes. So it's a difficult way to practice, if you like. So how to achieve better outcomes? But before that, let's talk about the window of opportunity. So we hear this all the time, there's a window of opportunity, but like what the hell is that? So it's very important to have a little bit of better understanding of window of opportunity. In simple words, what it is in that particular time frame when the disease responds best to treatment, and of course the long-term remission is better if we intervene in that particular window of opportunity. In simple words, that's what it is. And it has been recently estimated that even 1 week delay in introduction of treatment, there's a 1% lesser chance that 1% of the lesser patients would eventually end up having drug-free remission. So we lose 1% of long-term remission if we delay 1 week of introduction of biologic in these patients. It's very much established. We know that, of course, if we intervene early, then there are better outcome as regards the disease progression, as regards the radiographic damage, and of course, the drug-free remission, which is the best outcome that from the rheumatologist end, that we not only have controlled the disease, but we have been able to manage to take them off medicines. So if we look at what the time frame is, what particular weeks or months we are talking about. If you look at the data, for example, this is very famous data from the FINRECO trial, for example, they talk about the 4 months. That the 4 months you have to intervene, within 4 months you get the better outcome, more than 4 months there's a worse outcome. And on the same basis, the COMET study was designed when they look at the combination of the etanercept and the methotrexate, and again was the same, that the 4 months if you intervene, the same the combination drug given within 4 months, and after 4 months there was a different outcome. This famous Leiden, the Netherlands cohort, and also there is quite a famous, the French longitudinal patients registries cohort of the rheumatoid arthritis, and they have set points that how quickly you need to introduce these DMARDs in these patients. And what they talk about is the 11 weeks for anti-cardiolipin antibodies positive, anti-citrullintin and anti-CCP antibodies. So if somebody's anti-CCP antibodies are positive, so you have to start these DMARDs within 11 weeks. But if somebody's anti-CCP antibodies are negative, so you should introduce at least within 15 weeks. And there is a reason behind it. The window, because not only this particular longitudinal cohort, there are other cohorts as well, and they talk about that this window of opportunity starts to close after 3 to 4 months. And if we talk of specifically about the drug-free remission, which is absolutely the gold standard for our treatment success, that you have, as I said, you have taken the patient off medicines in the long run, and if you really want to achieve that, this window starts to close at 15 weeks if you look at the Netherlands cohort, and it's the 19 weeks if you talk about the French cohort. So within 15 to 20 weeks, we have to introduce not just the DMARDs, but the proper DMARDs and in a treat to target fashion. And very interestingly is a different phenotype, and that really adds up what we are talking about. If you look at, for example, the different phenotypes in the synovial fluid of these patients who have a very early disease, early rheumatoid arthritis, there are different T cell subsets, there are different cytokines in the synovial fluid compared to somebody who have got more established rheumatoid arthritis. And it really begs the question is that we are talking about 2 different disease subsets that probably the synovial inflammation, there's a qualitative difference in these two, but also probably that's the reason that they respond much more quicker, much more better in the longer run if we treat these patients in an early way. So not just the clinical data we have the molecular data to back this up. So this very early rheumatoid arthritis we talked about within 3 months, and still ERA in most of the countries they use the word that is within 6 months. But if somebody's disease onset or the symptom onset is more than 6 months, we need to be very clear we're talking about established rheumatoid arthritis. So it means that there's not a lot of time we have in our hands. So in very similar way, we talk about, for example, the psoriasis and psoriatic arthritis, that how it evolves from psoriasis to psoriatic arthritis. We know in the psoriasis, for example, and then there is a preclinical psoriatic arthritis. This is very much backed up from the molecular data, the slide that I'm showing you, that there is an aberrant immune cell activation, which is called preclinical psoriatic arthritis. Then there is subclinical psoriatic arthritis. This has been shown in, I don't know how many dozens of patients, that in psoriasis patient, if you do, for example, MSK ultrasounds or MRI, there is a subclinical inflammation. And these are the patients eventually would develop psoriatic arthritis later in the disease course. And then there is this prodrome PSA. And this has been shown by the Toronto group, that the patient who would think that they have fibromyalgia, but they also have got concomitant psoriasis as well, there is a significant majority of these patients which eventually develop full-blown psoriatic arthritis. So this prodrome of arthralgia, fatigue, and so on can prelude to the full-blown development of psoriatic arthritis. So let's talk about the treat to target. Again, we hear this all the time, in not only in rheumatoid arthritis, but in almost all the diseases that we talk about. In simple word, what this whole concept means is that we really need to set the target, whatever the target is. Are we talking about low disease activity, or we are talking about complete clinical remission? You know, the DAS28, for example. So we need to really sit down with the patient, look at the overall totality, for example, of that particular case, and then, so you have set the target, and you keep on assessing the target on more frequent basis, and keep on escalating the treatment until you achieve that target. In simple words, that's what treat to target is. It's very important in psoriatic arthritis as well, because there's a lot of confusion as regards. We know the minimal disease activity. This is a low disease activity. Even that's enough if we want to look at the long-term remission. That is very much accepted. But again, if you look at the full-blown remission, that is 7 out of 7 of that particular MDA needs to be fulfilled, or otherwise the DEPSA. So important thing is we really need to understand whatever our target is. And this is a systematic review looking at the treat to target, for example, all the clinical trials, the very good clinical trials, for example, the BEST trial, the first of the first, and they looked at the early rheumatoid arthritis, for example, intervention versus the established rheumatoid arthritis 6 months, more than 6 months, and looking at the intensive treatment versus the conventional treatment. Intensive means the combination treatment, the biologics and so on, and the conventional is that you leave the treating rheumatologist to decide whoever they want to start and whatever fashion they want to start with. And what you're clearly seeing is that there is definitely improvement as regards the achievement of remission, for example. So if you look at, for example, the left-hand side, the early rheumatoid arthritis, so the achievement of remission with the intensive treatment, you're able to achieve up to 60% or even up to 80%. However, on the left-hand side, if you look at the established rheumatoid arthritis, for example, in those cases, the remission, even you use intensive treatment, you are able to achieve hardly around 40% plus minus. So in that established rheumatoid arthritis, I've shown in this particular slide only the full remission, for example, the percentage. However, if you look at the low disease activity, in established rheumatoid arthritis, you might not be able to get 40% only full remission, but there will be 60 to 80% who still would be able to achieve low disease activity. So again, the very important thing, which was a little bit of surprise as well, that the treat to target, if you look at this particular systematic review, their conclusion, they concluded that this intensive treatment was more cost effective rather than looking at the convention in the long run. This one again, looking at after 10 years, those patients who were started with the treat to target, The combination treatment 11 years earlier, and after 11 years of this particular, when they looked at, if for example, if you look at the FIN-RACO trial, 37% of these patients were still in complete clinical remission compared to only 19% of the patients who were having those traditional or single drug treatment. Again, looking at the systematic review, talking about the same intensive treatment, again, I'm not going to bore you, but there's a lot of data, very much established data that we need to be talking about intensive treatments. So available options, we know that these are the three main groups. We have conventional synthetic DMARDs, the biologic DMARDs, and of course targeted synthetic DMARDs. So this is the treatment that we have come of rheumatoid arthritis all these years. It's a very nice slide looking at, for example, 1900s, if you look at that time how rheumatoid arthritis was being treated. It was hot water, the mineral baths and all this. And then 1920s, I was surprised to look at, they were talking about the blood cultures and all this at that time in 1920s. And then because it was taken as that this was an infective process going on. And it was in 1940s, then the gold injections started to be used, and then all these further classes. And 2019 was the main one, if we talk about that the biologics, for example, the DMARDs, that we had started talking about, that within 3 months we need to move far from conventional synthetic DMARDs and moving to more targeted therapies. So talking about the targeted therapies, for example, what we have got is, we know about the TNF blockers. Of course, the first one was etanercept and then infliximab and so on. So all these timelines, it's very interesting to look at how treatment for rheumatoid arthritis has evolved in all these years. And again, with the introduction of JAK inhibitors, naturally things have moved to a different level as regard the availability, the cost, and so on. So talking about the biologic DMARDs, so they were introduced in mid-90s, I think it was in 1996 or 97, and etanercept got approval. So these are very highly specific. They target a very specific pathway of that particular immune cycle compared to conventional synthetic, which suppress the overall immune system rather than the particular pathway. These are biologically engineered and come from biologically source, of course. The problem with the biologic DMARDs is that they're very difficult to make. They have a much higher molecular weight. Again, they're very, very specific compared to selectivity. They're much more specific, and that's why it has to be given, because of the high molecular weight, it has to be given in the subcut form or IV form. And their bioavailability is a lot less of these particular biologics. So that's why there's a lot of time we need to use the loading doses. And this particular, don't worry about too much about this, but I'm just going to highlight where science is going, how we're going to sort of try to overcome the problems of the biologic DMARDs. As I said, it has to be because it's a much higher molecular weight. So this particular, this is a fusion protein. This has been nearly approved. That is, I think is phase 3 trial is ongoing at this stage in psoriasis and psoriatic arthritis as we speak. So this is a fusion protein. What they simply did was they're simply changing the the weight of this particular monoclonal antibodies. They were able to achieve much higher affinity. For example, this particular IL-17 inhibitor, so they simply sort of change the molecular weight is, the molecular weight is only 1/8. You will be able to achieve high potency, means 1,000 times more potent. The molecular size is 1/8. And again, it's much, much, much more cost effective compared to the monoclonal antibody. Again, there's a lot of data already. I'm not going to bore you. This is another nanobody. So this is not a fusion protein. This is a nanobody looking at the heavy weight of that particular antibody. So simply changing those different sort of the antibody parts, they're able to make it into a much more sophisticated way, where even one shot of particular antibody, it will remain in the system for a number of months. So there's a lot of excitement in future. Hopefully we'll be able to get. Let's talk about the JAK inhibitors. So all these, we know the cytokines and all these are extracellular. They work on those cytokines, they block the cytokines. So what happens is when the cytokines are attached onto the particular receptors, these JAKs, for example, they are attached onto the intracellular part of that particular receptor. They get activated, they get phosphorylated, and those phosphorylated gets those docking sites. They phosphorylate. So in simple words, I'm sorry I'm not able to show you much, but simply the cytokines, the green one, they attach onto the receptor. So when that particular receptor is attached there, so that particular JAKs get excited, that gets sort of activated, it gets phosphorylated, in the next step is what you're looking at is that transphosphorylation of that particular JAK receptors leads to the tail of that particular intracellular receptor, it gets activated, and that becomes a docking site, if you like, for STAT proteins. So the STAT proteins gets attached to that intracellular receptor, and then that dimerizes well, that phosphorylates first, then it gets detached, and that moves on to the nucleus. I know it's a lot of scientific way, but it's a very simple, very easy way if you want to know that how this whole sort of the particular receptor blockages, not just the cytokines, but the intracellular cytokines, how they work and leads to transcription factors modification. And that is the important thing we talk about, is the selectivity versus specificity. So we know that the biologics are very specific. They target a very, very particular immune, whatever the pathway they're going to block. So the biologics, they are very, as I said, specific. But in terms of the JAK inhibitors, they are not specific. Unfortunately, that's why they use the word called selective for JAK inhibitors. And there is a reason behind it, because we know there are 4 types of these JAK isozymes, JAK 1, 2, 3, and the TYK2. So if we talk of, for example, let me explain you a little bit, or might be easier. If we talk of the biologics, it's like a lock and key. So there is a lock, and there is a one particular key that will get in there and will open the lock. And that's how specific the biologics are. But when you talk of the JAK inhibitors, it's like a finger in a glove. So that glove might not be really fitting you, but your fingers will still be able to get in there, no matter whether they're small or large. Does it make sense? So that's why they use the word selectivity. So what happens is when the intracellular cytokines, so in the top one, what you're looking at is that those particular cytokines, for example, if they're not that much there, then it's a little bit more selective there. So that particular, for example, JAK1 inhibitor, for example, argument's sake, we're talking about upadacitinib, for example, which they claim is quite selective compared to tofajak, for example, tofacitinib. So when in the level of low cytokines, so they're quite selective, they will attach onto that particular JAK1, for example. However, when there is a more cytokine signaling there is a much higher level of that particular cytokines, so that selectivity gets lost. And eventually, unfortunately, JAK1 will gonna block some other blockers as well. So that's why the specificity is lost. So here we are talking about the same. For example, these are non-selective JAK inhibitors. For example, when you're looking at the bottom, so this is going to block all those different JAK1, 2, and of course the TYK2 and all this. So that's what they're going to block. So there are going to be, of course, the good signals and the bad signals. There are going to be some, for example, the cytokines which are pro-inflammatory, some which are anti-inflammatory, and the same goes around for our, for example, tumor. For example, there are some JAK inhibitors which are used for the cancer therapy as well. So that's why non-selective is the JAK1, but then there are a little bit more selective as well. But again, these are not specific, just remember the word. So let's talk about the remission induction therapy. So this is very sort of the broader way if you want to look at the high risk, for example, rheumatoid arthritis patient. We all know, we all agree on the same one, that if somebody has a very high disease activity, naturally there's a high risk rheumatoid arthritis patient. If somebody has got quite high titers of anti-CCP antibodies, again, that we all agree that we classify that patient as probably a high risk patient. And we've already got the radiographic damage done. So in those patients, of course, we need to be a little bit more aggressive. We need to be talking about the combination DMARDs at start. That's what at least I try to do, to start off with the combination DMARDs, even the day one. And naturally, you also have got the option that in those patients, you can pick some other, for example, either the biologics or some targeted synthetic, if not at the initial, if not at the onset, but you should be thinking that at least start working them up for these particular next class drugs. And if somebody has got a low risk, we do come across with these patients with very low titers of rheumatoid factors. Naturally, we can take a pick as regards picking some drug we want. But again, there's only one thing that we need to remember, which is more important than picking which drug we pick, is the treat to target. Keep looking at the target, keep assessing the patient. If the disease is still active, don't shy in terms of increasing the drugs. And so the combination of the DMARDs, for example, if you look at them, just showing this just because we have our own patients as well, we checked for psoriatic arthritis patient. We know that the combination of the leflunomide and methotrexate, there is a black box warning from FDA because of the hepatotoxicity, but it has been used across the world that it is a quite sort of a well-tolerated way if a patient, of course, having poor socioeconomic burden, that these different drugs we can easily combine and is very much sort of effective, and the drug persistence is a lot better in these patients. So JAK inhibitors, we know that there are different ones, as I've highlighted there are selective as well, there are different indications as well. For example, these are the initial FDA approved indication for these patients. For example, with the tofacitinib, so these patients needs to be methotrexate inadequate responders before you start them on JAK inhibitors until the last year's FDA safety signal warning that you have to have better off having anti-TNF failure before thinking of starting on JAK inhibitors. So that has been changed a little bit since then. If you look at, for example, all these, the JAK, that 4 ones available, they have already been tested and of course trialed as well. And all these patients who have biologic DMARDs inadequate responders, and even in the methotrexate naive means the JAK inhibitor was the first drug tried even before the methotrexate was started. So challenges bring opportunities, as we say. So as I said, it's not easy to practice, so we always need to be looking at whatever best ways we can do for our patients. I'm sure we all doing our part as well to help people, to bring funds for them. Almost all the centers are doing this, so we try our part as well. So we have got more than 1,200 patients who are getting all these different medications, the oral medications. We have got more than 500 patients who get absolutely free of cost biologics as well. They come on very frequent basis, 2 weekly, 4 weekly basis, and get their biologics free of cost. And absolutely it has made a massive difference. This was the first child, as you can see, that how effective the drugs are. For example, again, we all have shared these patients. So the conclusion is, so as I mentioned, not only the patient with a low socioeconomic class end up having more arthritis, but unfortunately they end up having worse outcomes as well, not just having the high numbers. Addressing the disease activity, as I mentioned, and always keep looking at the target, what you want to achieve, whether it's a low disease activity or it's a complete clinical remission. It has to be very clear, and it's better be documented in the clinical notes so that at least we all keep on thinking about this. So before trying our weapons, we need to really knowing our weapons. Means we really need to be mindful of the drugs that we deal with. And again, this is a major thing because in our, of course, the settings, these JAK inhibitors, for example, they have started, it happened to me a couple of times, that once they go in the community, they might not show up for the whole year because they're sitting at home, they keep on getting their prescription renewed because they ring up the whatever the company they're getting from, and monthly their prescription are filled, and certainly when they come back to us and then there is a penny drops, that there's a lot of other complications are happening. So we really need to be knowing our weapons, as I mentioned, and naturally one size doesn't fit all, so it all depends on the particular patient sitting in front of you. Even a lot of times I tell to my sort of the fellows that the rheumatology is an art, it's not a science. So it's not something that you can say, oh, start with A drug or start with the B drug. It all depends on the patient sitting in front of you, that again on different comorbidities, for example, that what you need to be looking at. So addressing the comorbidities is the most important aspect in my eyes, because naturally they all could have comorbidity, for example, not just the cardiovascular risk, but a lot of time they have this chronic fatigue. I think, if I'm not exaggerating, every third or fourth of my patient on some antidepressants as well, if I'm not exaggerating. I'm talking about the patient who have got more established treatment. Naturally, the patients who are coming early, naturally they get very, very good response and they don't end up having all these comorbidities, but usually the impact of this particular arthritis, not just their physical functioning, but also their mental sort of their psychological well-being is not the best. So that's why we should be looking at the totality of that particular patient's lifestyle as well. And the worst of all I've seen also is the concomitant, for example, the Zika symptom, the Sjogren's disease also comes with, for example, the rheumatoid arthritis. And that again is quite a challenging one, a very, very difficult one. And as we all know, we don't have any dedicated treatment, for example, if you think of for these dry eyes and dry mouth, and hopefully future would have. Dr. Fazl Sahab have asked a very good question as well, is about some treatments. They have been off-label used. Some have got very, very good response. So we need to be, of course, looking at whatever options we have to increase the lifestyle or quality of life of these patients. So, thank you.